Yes.
Okay, since I did it before. Okay, so as a lead into Bernie's talk, the secure carriers from pharmacy that started Monday, 3 West has been trialing them. They started hospital-wide on Monday. We're just talking a little bit about it because we have gotten some feedback from pharmacy that staff still don't know what they're supposed to do with the secure carriers and how to release them. And since this talks about meds, it would be a good lead-in for Bernie. So with the secure carrier, pharmacy will send it to you if any meds that are in pharmacies up in the tube system. Your tube system will beep at you when there's that secure carrier that you need to release. Every tube station has a little step-by-step on how to release the tube. So what you're going to do is go up there and hit the special key and enter 76 to release the secure carrier. And then when you're prompted, you're going to use your 3-digit authorization code, which is 500 for 500 East Market for our address. Very easy to remember.
PCA code.
Same PCA code. So we try to make it easy for you guys. Once the central center has approved your request, it will drop the carrier, and you just have to hit send to clear the message. If you don't drop the secure carrier, no other tubes can drop, and you don't have a backup in your system until the stuff can drop. If you have any problems delivering the secure carrier, you can notify maintenance, and they'll manually get it out of the system for you.
And then make sure that you lock up the medication
Yes.
or hand it to the nurse who
Yes.
will be handing it. That's the point.
You can't just set it on the counter. Our techs and unit clerks can get into the system and get the meds out as long as they physically hand it to a nurse.
So I'm assuming this is just controlled substances.
No, it's
Any medication now we're using this. So because that way they were just dropping and sitting in the tube station for how long until we got
Yeah.
the nurses got them, and meds supposed to be in your site or locked up. So any meds come through the system. If you take them out, put them in the patient's locked med drawer or give them to the nurse or put them in the med room.
This is driven by Joint Commission.
It is a joint
In terms of security of just meds in general,
Yep.
we have to have control of them, even more so than the controlled substances. So,
So any questions
All right.
about that before Bernie starts?
alrighty. Well, your nursing leadership asked me to come and talk to you about your practice with controlled substances and kind of what's going on with your practice here. For those who don't know me, I'm Bernie Brandenburg, and I'm Director of Nursing. My background's mostly ER, but I got a lot of other stuff littered in there. Up until 2 months ago, I was still doing ER work, so I'm very up to date and in the trenches with this kind of stuff, as well as the administrative side of investigations and the legal issues. So in that regard, gosh, that was slow. Okay. Today we're going to go over the policies and expectations, review your nursing license, talk about the security of medicines, medications, even more so than just now. Chain of custody, controlled substances and wasting, documentation, then consequences associated with this, go over the frequent flyer scenarios that are encountered in the investigations, talk about the code and surveillance process here, and there's a colleague practice acknowledgement that you have. That being said, right off the bat, they'd asked you to look at a number of different policies before you came here. Again, they are the controlled substances in and out of Pyxis, the pain management policy, security of medications, both in the pharmacy and nursing, admission of a patient and ordering medications, medication administration in general, and the pharmacy policy on controlled substances. Okay, very important that you know that those resources will answer questions about what needs to be done with controlled substances and to guide you as you deal with them. All right, just went over that, sorry. All right, so I want to talk a little bit about your professional duty, your licensure, that type of thing. Our responsibility associated with being able to function with controlled substances in our practice emanates from the federal government, the Drug Enforcement Administration, okay? Past the Drug Enforcement Administration, there's also federal and state controlled substance acts. And then you move into state related regulations associated with the Board of Pharmacy, and then also the Board of Nursing. So as you can see, the lineage of regulation is pretty complex, but it's very important, and it's pretty cut and dry, okay? What I've listed here are some of the more frequent types of charges from a law standpoint associated with nursing consequences from the Board of Nursing. Just wanted to bring these up because from the standpoint of this one through the Iowa Administrative Code, misappropriation of medications is involved in that with that citation. Unauthorized possession or use of controlled substances in work. Dependent adult abuse or neglect is also in there. Habitual intox or addiction and the use of drugs, even on the job. And then this one kind of sneaks up on you after all is said and done with these, falsification of records. So you can get into a combination of those types of charges if you're not really responsible and holding yourself accountable to the use and responsibilities of controlled substances. So I want to go over the consequences because it again provides you with the complexity but the severity of issue associated with these, okay? We all love our livelihood, and when I investigate these and other people that help me investigate these, I take everybody's livelihood very seriously. I don't want anybody that I'm looking at not to have some type of a mistake associated with what I'm finding. And so it goes through a couple double checks and that type of thing, because this is serious. It starts with your employment status, and that can mean some type of discipline, likely, or termination, okay? Moving on, you've got your license. We all, our nurses, we've all got the baseline of what the Nsg Practice Act has allowed us to do through the different DEA, Board of Pharmacy regulations. And if you're terminated, or even if you do have discipline associated with some type of conduct with the controlled substances, the chief of nursing can certainly indicate or recommend that we report you to the Board of Nursing. That means you're going to have to defend your license somehow, some way, okay? Other situations, perhaps if it goes even further and it's pretty darn serious, we have to report to the DIA if there is some type of abuse or neglect that we have suspicion with in the investigation, or if there is some type of loss of medication. If we're not finding waste, if we're not finding the drug, we can't account for it. There's a threshold within the pharmacy that we as an organization have to report it to the Board of Pharmacy, but we also have to report to the DIA. Can anybody guess what happens when the DIA gets a hold of it? Yes, if you're wasting a drug associated with any type of transaction within the investigation, they will interview you. Anything associated with you being a part of a Pyxis transaction or documentation associated with that drug, they're going to interview you. They're going to scrutinize your wasting routine. They're going to scrutinize your documentation. And they're certainly going to question patterns of behavior that they see associated with it. The great thing about the DIA, they like to talk to DHS from the standpoint of the abuse and neglect. But they also, if they find issue with anything that's going on, say a nurse is acting outside their scope of practice that they determine based on regulation, They will report the nurse to the Iowa Central Registry. Does anybody know what that is? It's the Direct Care Registry. If you are put on that, I know of no one who has been successful of getting themselves off of it. What that means is you will never, ever get to practice nursing as a direct care provider again in the state of Iowa, probably anywhere. You will likely be doing nursing from a phone or nursing from a desk or something like that, trying to utilize your skills and knowledge if you continue. But you cannot touch a patient again. So the other thing that happens with the DIA is if they say we've done an investigation that involves 9 patients that didn't get a certain drug because it was diverted. What they like to do is send each one of those patients the file of the investigation. What does that do? Yes, they do. They name you specifically. Now, many lawsuits from a medical malpractice standpoint only name Mercy Hospital. But when you get into something like this, they will likely name you as well as the hospital. If you have not followed policy in the hospital, or we feel as though you have not abided by your license responsibilities, Mercy will divorce you as a defendant, essentially. You will have to defend yourself. You will have to pay the damages yourself. I can tell you that's happened twice in the last 20 years since I've been here. Okay? Short of having criminal charges going through the criminal charge process from the DIA, getting into civil lawsuits, there's one last and final possibility, which is very problematic, which are federal criminal charges. I've not seen anybody here go as far as getting federal criminal charges, but if you remember about 2 years ago at Methodist in Des Moines, there was a pharmacy tech that pilfered fentanyl out of about 140 patients. Yes, not 140, 740 patients. It was huge. And they could substantiate that he had taken those drugs, he admitted to it, and that passed go and went straight to the Drug Enforcement Agency and the federal level of criminal charges. So there are very significant consequences, and it's not just, oh, you're going to be fired kind of thing. Your license is in jeopardy in many different fashions. And then you have a long order of legal matters as well. Questions about these? Okay. I want to talk about some scenarios. First off, who can tell me what the chain of custody of a controlled substance is? Yeah.
A chain of custody is where it shows when it's gone from person to person. So pharmacy brings it up, puts it in the Pyxis, they log it in, that's the first chain. You go to it, you take it out, that shows you are in possession of it. You take it to the room, you give it to the patient, you chart it, that the chain of custody ends there.
Mm-hmm.
Once you've given it and it's all charted. If you have to waste it, there's another step in the chain of custody. It's just like chain of evidence for a police thing.
Absolutely.
It has to be traceable.
Well, it has to be more than traceable.
It has to be documented.
Has to be documented as well, but it has to be one more step of
It has to be within your scope of practice.
it has to be you.
Yeah.
Right.
I mean, pharmacy drops it off in Pyxis and that's where theirs ends. The minute that you take it out of Pyxis or the minute that you obtain it from pharmacy, you are babysitting that for life. It is your baby, and you have to provide the protection of that entity until there's a disposition of it, right? So you're taking it out of Pyxis, you're administering it, you are wasting it appropriately with a second person. So can anybody tell me possibly any scenarios that might not need to adhere to that?
Emergency, like an emergency intubation
Well,
Medical emergency.
intubations typically don't use controlled substances.
Sometimes they use for I'm
Mhm.
just trying to think. Somebody gets a drug for you and brings it into a room in an
Narcan.
emergency, perhaps?
I don't think there's any.
There's none.
Yes, there is.
There is.
Think of you coming into a room where a patient is in status epilepticus. You're the primary nurse. What are you going to do? What's the first thing you should be doing? Protecting the patient from harm to themselves or others. Right?
Right now.
Then you yell for help. You ask someone to go and get Ativan. They bring it into the room. You're the closest person that can give it. You're the one that gives it. You're not the person that took it out or drew it up, right? It's that significant, life-threatening, staff-threatening situation where you have some kind of defense. But I'll tell you what, I've done some investigations where people claim this because they're busy, because someone's very acute. And the very acuteness doesn't mean it's emergency. It has to be very, very life-threatening, safety-threatening type of situation. That makes sense to people? That is defensible, all right? What I would do in that case, from a standpoint of documentation, I guess maybe I should ask you, what would you do if you were the nurse, primary nurse in the room that gave that, and someone brought you the drug? What would you do for documentation?
Hold from Texas by so-and-so RN and
Have them co-sign it.
Absolutely, both of those. You document it in the medical record that it occurred that way, and you have the other person co-sign it. Basically, that tells everybody what happened, and there's no guessing. There's no guessing to go back and put the pieces together to see how emergent it was, or who did what with the drug, through it, in the event that there's some type of opportunity to divert that drug. You want to close those holes, okay? So that's chain of custody. And to waste, what is the proper way to waste?
Stand there and watch them.
Okay, what are you watching?
Watching them draw it up, you're watching them squirt whatever out, and you're checking your dose, and you're documenting.
Is that your routine all the time?
Yes.
You're watching people who actually take it out of Pyxis. It's labeled. If it isn't taken out of Pyxis, say no one was there and I had to go give it on a night shift. No one was there when I had to go get it. I went into the patient's room, gave partial, and there's still some left over.
We're not supposed to do that. We're supposed to do it at Texas.
Yeah.
At
You're not.
You are, but if you don't have someone there to do it, what do?
You stand there and wait until somebody can get it.
Yeah, you should have something labeled, like your syringe should be labeled. And you should be, again, watching the witness, watching the waste. You are witnessing the fluid, because they could try to divert something however they want to, but your routine should be the same every time. It's not saying, oh, here's my fingerprint, and oh, I got to get this out of the counter. I trust you. Mm-mm. We had a situation with a nurse right about 10 years ago now. It was actually a nurse who recognized another nurse, started asking her to waste a lot more at night. And then the nurse reporting that actually indicated that she recognized that nurse was itching a lot. What do you think happened in that scenario?
Some addiction issues.
Yeah, she was diverting morphine, and what she would do is get morphine at the beginning of the shift, and at the end of the shift, she'd get lorazepam, take home with her till she could come back to ward off withdrawal. Yeah. So, all right, I want to move on to PRN orders. PRN orders are special orders. They have to have the dose and all that kind of stuff, but the main thing the PRN orders have that are different than other orders are there's a specific indication why you give that drug, right? Okay, so what's come up in the last couple groups of this is perhaps an oversight on nursing's part. It's fixable. But say I've got a patient that I just assessed to have a level 3 pain, and they're getting ready after their total hip to go out and have physical therapy. What are you going to do for their pain in physical therapy?
Pre-medicate?
With what?
A controlled substance.
Yeah.
Are you going to use the order that you got?
Yeah, you need to order.
Yeah, the new order only says give for mild pain, or moderate pain, or severe pain. And if you're assessing it right now and it's not there, you can't do it that way.
What if your order just says for pain?
You can't. That's when there's pain.
It needs to say.
Yeah, if they rate their pain as
pre-physical
a
therapy.
3 and they're about to work with physical therapy, and it just says pain.
That's futuristic, that's guessing.
Or severe, or it has to say
Bottom line is,
before physical therapy.
So
Yep.
isn't 3 mild pain? That's pain though.
pain is mild pain, but the bottom line in this and the point of this is you have to get an order that says pre-medicate. You can't give that order for mild pain, just mild pain. If that's the I mean, basically, patient, let me back up a little bit. I'm saying the patient has a level 3 pain right now. They're getting ready to go to PT. What's been happening is people are using the moderate or the severe PRN pain medication to pre-medicate those patients. That is outside your scope. You are prescribing a drug and giving a drug.
You have to have pre-order Medicaid.
Yes, you do. Now, that's been brought up to nursing leadership, and that's going to be worked on. So don't have a cow over that right now. It's an organizational thing that we're going to fix. But the bottom line is those PRN orders are very important that you give only for those reasons. You don't give Benadryl to sleep when it says the indication is itching, do you? How many times do you think you've tried to do that? Or people in the past have done that? I've seen it. That also speaks to out of scope. And even in the process of doing some of these investigations, some nurses have been reported to the Board of Nursing for that. It's not a controlled substance, but it's outside their scope. Okay? Holding on to a drug too long to give or to waste. How long do you think is too long? How long do we typically have to give a medication?
An hour, 4 hour after, I always go get it when I need it.
Depends what you're doing. When you're in a procedure, you might be in a procedure for 40 minutes.
Mm-hmm.
And then if the person needs to be recovered very closely, we just lock it in a drawer until we can waste it later.
That's your process right now, and that's been brought up. But do you think in 2 years, someone will know that that was the process? I recommended to Sally this morning that if you've got that going on, this is the situation. Someone goes in radiology to have a biopsy. They give Versed and they give fentanyl, right? In the biopsy, there's some fentanyl left, but they also know that there's some procedure orders that also allow the administration of fentanyl. Would you rather spend 30 cents on behalf of the hospital to have a clear process and know that is not depicting some type of perceived diversion trend, or $10,000 to defend your license? The hospital doesn't care about the 30 cents that it costs to save that drug in that manner, just to bridge something together. It is not, it is far more, I guess it's far more clean to waste the drug after the procedure, and when you get to the next phase of care, you get fentanyl out again, okay? Because the process is going to be that no one's going to know that you locked it up. That's the problem. You've got it right now, and that's all fine and dandy, but it's not going to.
The other thing too is that sometimes you're totally by yourself. Like on a weekend, you have to come in and do a procedure, and you're giving those meds.
Mhm.
We have to wait and waste those meds after we take them upstairs with a nurse upstairs because you're by yourself.
Yeah.
I mean, who do you waste with?
Okay, going back to the first question, how long do you think that it should be to waste a drug? I'm okay with up to 30 minutes because things happen. 45 minutes, I'm looking into what's going on. Past that, if it's taken longer than that period of time, you have ample time to divert. And that's going to be looked at and scrutinized far more closely.
So we should, I mean,
Yeah.
what do you do when you're by yourself and there's no one else?
Do you not have a doctor there?
They go to another room, they go back to
You
the
call,
waiting room.
on a weekend, you call the ADON to come and waste with you.
And then who's gonna watch the patient? That you're recovering? You're by yourself.
To waste with you. Or, what I
You
mean,
gotta waste the pictures, the
it's
pictures
not
is in a
in
different
our
room. You,
She's staffing.
we have to step out of the, into another room to waste. The pictures is not in the nursing station.
it's not in there anymore?
No.
Well, we probably need to look at that a little more closely. I wasn't aware of that. So, bottom line is you need to obviously waste it as soon as possible. That's a good question. I don't have a good answer for you right now.
Because there's only 2 staff, there's no one on the weekends in the radiology department, so there's 2 people, and they're just techs.
So, when you're doing a biopsy on the weekend or what have you, is there not a CT tech or another tech that has privileges to get into Pyxis?
And not for wasting, they cannot witness us, it has to be another RN.
Does it? The ER uses paramedics. What does our policy say?
They don't take out any narcotics for us at all.
Okay.
I don't think that they can.
If they don't have access, then you can't use them. You can use whoever has access.
Usually people be
Yeah, Joan?
So as a stopgap, would it be okay if, say, they have that, and, okay, we're not nuts to bolts in the ER, can they call one of us over
Mhm.
to
Yeah.
waste?
Yep. Yeah.
Well, I've gone to the ER to waste, but the problem is then there's no one monitoring the patient.
Right. Right. So, I mean, you obviously have to get someone there, but yeah, you don't leave the patient.
No.
No. But bottom line, we'll probably have to take a better look at that.
We will take a look at that. She's written down that statement. We'll be taking a look at.
My question would be to you in that regard is how do you know that you're done giving the drug so that, you still have drug? You haven't recovered them fully. You still have an order that is active. You might give more, so why are you worried about that to a certain extent until you take someone outside of that phase of care? I mean, that's a way to think about it too. But either way, what it's going to do is reflect that amount of time on you, which you need to be conscious of, definitely. Okay? So does 45 minutes, half an hour, 45 minutes in terms of waste make sense to you guys? Otherwise, it speaks to a behavior trend that gives pause to character and integrity. And do you know what you're doing or don't you know what you're doing? Or are you being devious? Okay?
Bernie, earlier
Yeah.
you had talked about a situation where they would pull out a drug for a physician who then administers it, anesthesia being the group that was being talked about earlier, and you talked about a variance report.
Yes. Now if I'm trying to remember that. The scenario was, say in surgery or something, ER, for an epistaxis, they'll pull out cocaine. And that cocaine needs to be poured onto the sterile field and someone leaves. That's not the right way to do it. That person that has the cocaine, that has poured the cocaine on its sterile field, you still have to maintain that chain of custody. If that's disruptive from the standpoint of a physician using it or doing something with it that it hasn't been essentially witnessed, you have to put the organization on notice because that can be missing drug. And the first person we're going to look at is you, right? When it's not you. There's some other examples too that are going on right now. For instance, in OB, and we have to work on this as well, but the nurses are getting out the fentanyl PCA for the epidurals. They're setting them up and just leaving them to the anesthesiologists. What's wrong with that? I've seen nurses, I've seen doctors take needles and pull the drug out of the cartridge or out of the tubing. for diversion. Okay, if you're setting up the cartridge, I'm not sure that the cartridge is the cartridge essentially, but it has to sense a volume. And if your PCAs are really tough, but it's really easy to divert off a PCA. They're a lot tougher to investigate, but there's a lot of opportunity there. And that leads me into the PCA keys. You know, I can understand that you're busy and you want that PCA key all day long. So it's easy for you, no problem like that. But every minute that you keep that PCA key with you gives pause to opportunity, right? You guys don't have bioreaders to get into every PCA pump to know who's getting into it, do you? So whoever's getting into it has that PCA key, right? So if you have that PCA key all day, guess where we're going to focus? Just be cognizant of those types of things, okay?
Should definitely take the med keys off the PCA keys on like tele and for some of them. You know, some of the rooms have the med box on the outside of the room. On, I can't remember if it's both or one of those units. The PCA keys and like the spare ones to get into those are on the same ring.
They were taken off on Force Center, Dustin's unit that had those off that way, and they took the PCA keys off of the keys for the boxes outside the room.
Good deal.
Thank you. Thank you. The other thing that I've talked about a little bit already is the pain management documentation. Again, when an investigation occurs, it goes straight to the physician order. It goes straight to pain management documentation, any other documentation, and then the medication or the EMAR. Okay. Then we go to Pyxis, look for waste, and build a story. Right. Pain is an interesting thing. We've already kind of talked about it with the pre-med kind of thing. You have to make sure, again, you're giving those drugs for the indication. But some people have said, well, patient might say they're a level 10, but they don't look like they're a level 10. What am I going to do? Or someone's got to saying they're a level 3, but oh gosh, they're stoic, you know, they're half tearful, you know, I know they're hurting more. My answer to you is there's more tools in your toolbox to actually document or use and document to assess pain, right? You got FLAC scale, you've got objective, you've got subjective assessment, you've got what the patient says, you've got scales, you've got all those things, right? So all those pieces of information together, you have to come up with the answer. Are they mild, moderate, severe pain, or you know, whatever the order is saying. You have to do your best with those scales, but you better get something documented appropriately that actually allows you to use the order that you're using. Okay. Another one, home supply of controlled substances, especially for people admitted. For people that are in outpatient areas and ER, it's not as important, but the minute that they're admitted to the hospital and patients bring their treasure chest of meds or whatever they have, if you know that one of them is a controlled substance, grab someone and count it. Because the minute that you don't, that patient is going to blame you for taking it.
Where should we be putting controlled substances then? If a patient has them, do we send them back?
Well, Kim Volk will tell you gladly.
We're working on it. So not all the units have a place they're supposed to be in a double lock type situation, and all the units have that. So we're working on getting that taken care of in your units. But in the controlled substance policy, there's a form that you can use to document when you get a controlled substance from a patient from their home meds. They'll count them, document it, sign off with another person, and put that in the chart.
If anything, put it in some narrative comment in the patient's chart.
Can you repeat what she says?
I'm sorry?
Can you repeat what Kim just said? Because
Kim said that there's a form actually out there for home-related medications that you can actually account for the drug, and it's a long grid kind of thing that, if they're going to use it, you count it as they take it. If there's an order for the patient to use their home meds, but that is the mechanism right now to use to keep that. I just said that, if you don't remember that form, put it somewhere narrative in the medical record that you and so counted the drug and it's this, and have the person co-sign it.
The best scenario is to send it home with the family.
Yes, thank you.
Don't ever take custody of those narcotics. Document that they took them at home, but we don't want them here if possible.
Yeah, we just had a claim, actually. A patient claimed that we lost her Dilaudid, imagine that. And we did a lot of sleuthing in terms of the primary care provider and the pharmacists to figure out that it was really Lortab. And then it came to be a matter of, well, how many tabs could there have been in there if she used it appropriately versus what possibly was there. We couldn't do that. We still had to pay the patient for the loss because it was actually documented. There's documentation that there was pills, but we didn't double count it, we didn't take care of it, and we had to pay the patient for it.
When you say a double locked cabinet or whatever, what do you mean by double locked?
Has to be behind 2 locks.
So,
So right now, that's where we need to get to, but we don't have that
Yeah.
available in all the units, so.
We're working on it.
We've got a lot of
that means nothing of ours is double locked, because we don't have a lock in the middle.
We're working on it.
Yeah,
Okay.
There's an
Yeah.
interpretation that we need to go through.
yeah. Joan?
So currently, if the patient is admitted from the ER,
Uh-huh.
say late at night, no family, and they have their bag of med, we've been taking and going, hi nurse from Five Telly, here's their patient meds. If we see in the ER that they have a controlled substance, should we be counting that pill
You betcha.
with the receiving RN?
You could do that with a receiving RN or someone in the ER that's a nurse if you have someone available. But either way, yes.
And then the
it's
receiving
documented
RN needs to do
in
the
ER
same
that
thing.
We
Yeah.
counted 15 pills or whatever.
Mm-hmm. Mm-hmm.
Probably when they become in their possession, they need to.
Yeah.
If